Firstly, I'd like to introduce myself. My name's Christina McNiven. I'm one of 2 liaison advisors in Scotland. Normally, your person would be Kirsten Baird, but unfortunately, she's off today, so I'm covering for her. Generally, these sessions are very informal, so really happy for people to ask questions. I may have to flick, for those of you online, I may have to flick back and forward between teams to see what questions you've asked. But yeah, as I say, keep it really informal. Sometimes this session can, sort of bring up experiences that people have had in the past that can be challenging. So just a reminder, this is a standard thing that we say at every session. This is not specifically aimed at, Kirkcaldy in particular. It's just, a respectful space. And yeah, we say it every session, but, it's very much not needed. So my role as a liaison advisor is to come out, talk to doctors, talk to medical students, talk about our standards and guidance. Normally, everything that happens in the sessions is completely confidential. It's kept, within this space. Unless something were to indicate a risk to patient safety, then that's something we'd have to, escalate a bit further on. So just the aims of today, we want to raise awareness of differential attainment. I'm going to talk a lot about Black and minority ethnic doctors, and also doctors who obtain their qualification out with the UK, so international medical graduates. But really, what I'm talking about today is relevant for everybody. So it's that rising tide floating all boats, especially doctors, though, with protected characteristics. So get involved. Please do use the Menti. I'm going to use it to stimulate discussion. And yeah, be obviously respectful of confidentiality of colleagues and, patients, avoid specifics. As I said, it can be a sensitive topic. So, just that compassionate understanding. So just so that we're all on the same page, so we all understand what we're talking about as the GMC around differential attainment. It's that unexplained variation in attainment between groups who share a protected characteristic and those who don't share the same characteristic. So, for example, age, gender, race, and it's really important. Fairness and equality are absolutely crucial, and we need a diverse workplace to, be able to, improve outcomes for patients. So it is really, really important. And obviously, differentials that exist because of ability are expected and appropriate, but it's that unfairness that is really important that we need to tackle. So you may or may not have seen this report before from 2023. And we also have an education data tool on our website. So if that's something that you want more information on, please let me know. I will also share the slides with Anne, and she'll share them around. No, absolutely. But I think it never hurts just to have, backup photos. And this is really, it's shocking there. You can see the statistics of that gap that there is. And as you can see, specialty exam passes are lower for disabled trainees, and we know that overseas graduates are less likely to declare a disability. So that's why it was so important for us to set targets. The GMC set a number of targets around equality and fairness. The one we're going to focus on today is this medical education one. There's been initiatives to tackle, this discrimination since 2015, but there's been very little movement. So that's why, in 2021, 10 years ago, we made a renewed effort to eliminate discrimination, disadvantage, and unfairness within 10 years. I'll be honest, we publish an ED&I report every year. We're not doing well against this target. We're doing better against disproportionate referrals of doctors by their employers from a Black and minority ethnic background and international medical graduates. That target was set for 2026, and we're on target to hit that, which is great. But this target we need more work, and that's why we're doing these sessions. It's really important to raise awareness and do as much as we can. So we publish that report every year, so you can keep us accountable. But it's really, really disappointing that we're not further ahead, but we are. It's the right thing to do, to set a target and work towards it. Oops, gone backwards. So some of the work that we're doing is obviously raising awareness about differential attainment and trying to build confidence in the profession to have those difficult conversations. Because if it's all swept under the carpet, then it's not going to get tackled. So we're developing practical tools. So you can see there, promoting excellence, which is supporting organizations to design and provide educational and training to meet the requirements of that document. We also share our data. So we report annually on the progression of doctors across the UK at key stages. So including how prepared they are for their first year foundation doctors. So that's all included. And we also publish and commission a lot of research in this area into the evaluation and impact of it, and research into the interventions to prevent it as well. You'll all be familiar with the updated Good Medical Practice, came into force in January in 2024. And the updated standards have a really strong emphasis. And we're hoping that doctors, employers can use this as a lever, around creating respectful, fair, and compassionate workplaces. Because these types of environments enable good teamwork, they make everyone feel safe to speak up and empower that good quality patient care. And crucially, help retain doctors as well working in the UK. A publication, I haven't put an image up, that this comes from is our 2017 report, Fairer Training Pathways for All. And it highlights the extra risks there are for Black and minority ethnic UK graduates, international medical graduates, and women. And it just highlighted the fact that these groups faced additional risks. And you can see there that perception of unconscious bias leads to poorer outcomes. And the fear of being labeled problematic, impedes the reporting of racism. So we really need to tackle these sorts of things. So over to you at this stage. What could reduce the risks for trainees? You can either put it in the chat or put it in the Menti. Hopefully that question will have come up for you. I'll just check there's nothing in the Teams chat that I'm missing. Okay, nothing that I can see at the moment. Okay, please do feel free if you want to unmute yourself, if you're online as well, if you have any contributions throughout the session, more than happy to do that. Yeah, these are fantastic. Thank you. Yeah, with regards induction, I don't know if you're aware of the SING group. So this is the Scottish Regions IMG Network Group, and they've set a number of essential and desirable standards for induction that we're hoping to roll across. And as I said, that induction, if it's improved for one group, it should be escalated round and improved for everyone. There's softer landing, safer care as well. And I can send you more information about that. But yeah, absolutely. I couldn't agree more. Inclusion is so important. Having inclusive teams, having supportive teams. I don't know how chatty you're feeling. I don't know, what could be done how do you make an inclusive team? And you may not have been the people that put this in, but just any suggestions or any ideas?
Having all the team there on day one.
Yeah. 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 I think that's really good. We don't have many people in the room. One person has just said maybe having everyone there on day one. Absolutely, you know, that's a great suggestion for building that inclusivity. Yeah, challenging the far right. Yeah, absolutely. I think there's the bystander duty now within good medical practice. So there should be policies within NHS Fife around if a patient is racist or if a colleague is racist. So there will be internal policies. We also have a racism hub on our GMC website. So yeah, not everyone is going to feel confident to challenge in the moment. I think in an ideal world, you know, that would be something there wouldn't be saltires flying in the streets. I never thought a day would pass where I would be ashamed to have a Scottish flag flying in the streets. But unfortunately, we're in that wider societal place at the moment. So yeah, bystander duty, local policies, challenging where you can, and raising concerns and escalating. So if you do see something racist or someone makes a racist comment, then escalating it up through the proper channels. So thank you for that addition. I think that's really important to raise. Thank you everyone for all your contributions and not dismissing. Yeah, absolutely. And I think not dismissing not just the bigger things, but also we're going to talk about microaggressions later, but the steady grind of maybe not feeling included, not feeling, just people not having that cultural humility to find out about their colleagues. Okay, so thank you all of you for that. Some of the suggestions we had around protective factors was that inclusive workplace. So you absolutely nailed it. Induction, you nailed that as well. And trainers having time to get to know trainees can increase trust, understanding and confidence, especially for international medical graduates where cultural differences might impede relationships. And trainers telling trainees that they have faith in them. So there's lots of things. There's, I think it's on the next slide, actually, just the huge importance of the relationship of the supervisor. Is the supervisory relationship is recognized as key in determining whether an IMG trainee is likely to be subject to differential attainment. So really important. Another couple of reports just to highlight to you, just to make you aware. So Fair to Refer, this was, I think, published back in 2019, and this was around Black and minority ethnic doctors from the UK were 2.5 times more likely to be referred to the GMC by their employer than a white colleague. And international medical graduates were 3 times more likely to be referred by their employer. So that's the target I was talking about earlier, to eliminate that disproportionate referral. So we're on our way to do that by the end of this year, which is a good starting point, but we can't take our foot off the pedal. We can't become complacent. This is still incredibly important. And the caring for doctors, caring for patients. This was Professor Michael West and the late Dame Denise Coya, who, again, back in 2019, looked at what factors did doctors need to feel supported. And they made a number of recommendations. I think the key one being compassionate leadership, but also they made a number of recommendations under the headings autonomy, belonging, and competence. So some really, really key reports and really important. So going over to feedback conversations, have you ever been on the receiving end of a poorly delivered, feedback, and how did that make you feel? Yeah. Angry, there's no need to shout, absolutely. Ignored, not listened to. failure, incompetent. These are all just so demoralizing. Failure, letdown. Yeah, it really is awful. And you do, I think, you know, everyone's human, and you take it so personally, if that feedback is delivered really poorly. So thank you for that. Incompetent, yeah, all those feelings, really, really challenging. And we know that the detrimental impact on just the well-being to the trainee and to relationships as well. But there's also that knock-on effect to patient care. If the doctor's confidence has been damaged, if they then avoid, you know, dealing with colleagues, certain colleagues, then that could result in missed training opportunities, and fearful for asking for help and support. And in addition to this, you're probably aware of our national training survey. I think of the most recent one, the results were 21% of trainees didn't feel that they could escalate a patient to their supervisor, to their, just escalate a patient up, which is shocking. That's nearly a quarter of trainees at some point felt that they couldn't escalate. And that's maybe not necessarily because of feedback, but it is that culture of feeling, that you can make a mistake, without being either ridiculed or made to feel small. We all make mistakes. It's the way we learn. So I think a culture of learning rather than a blame culture is really what we're wanting to ideally go for. So conversely, have you ever felt, have you ever received good quality feedback, and how did it make you feel? Hopefully you all have at some point received good feedback. Good, supported, yeah. Oops. Yeah, positive and competent, valued member of the team. Yeah, absolutely. And encouraged. Yeah. So important. Thank you everyone for that. Yeah. And I think the important thing when we're talking about good quality feedback as well is not good job. Why was it a good job? What did I actually do that was good? Can you be specific, please? I mean, it's nice to hear good job, but it's also nice to know why it was good. So again, another report. I feel like I'm just, throwing reports, but we do a lot of research and we want to share it with people. This is from our Good Conversations Fairer feedback, and it talks about all the conversations and what positive what positive things come out of that. So in 2018, we launched a program of work supporting a profession under pressure, to look at the quality of feedback. And this report was written by 2 of our clinical fellows, and it gives us a better understanding into the impact of feedback. So it can be inspiring. It's critical to building those trusting relationships as well. And I think we can all think back to when we've had an awful experience, and it really can almost traumatize you, and you carry it with you. So it's so important that those early conversations that you have are more positive. As I said, poorly delivered feedback impacts on asking for help, and it leaves trainees feeling disconnected and insecure. And in more than one case, poorly delivered feedback, can lead to people thinking of leaving the profession, which is obviously something that we don't want. So the recommendations in the report are here, talking about giving and receiving feedback, into having feedback conversations, and being aware of cultural differences. It's really important that that's recognized and reflected in feedback conversations. Obviously, bearing in mind, we know everyone's an individual, but just having that awareness. And feedback and reflection should be carried out together, and encourage feedback conversations to be the norm, rather than it's only when you've done something wrong that you get feedback. It should just be part and parcel. and trainers should be mentoring trainees with protected time. And all doctors should reflect on their feedback skills and discuss this at appraisals. So we're talking about effective feedback. What are some of the barriers that you may have come across with feedback conversations? Not appropriately trained, yeah, absolutely. Vague statements, yeah, time is a huge one. So that, yeah, generalized feedback that's not related to specific facts is definitely one. Not giving advice, personal digs, yeah, that's not acceptable. Not receptive. Okay, so I wonder if that's a trainee not being receptive. Okay, so there's, you know, things on both sides, people being open to giving and receiving feedback. One of the ones that was highlighted was a lack of respect for the source of the feedback. We accept feedback more from people that we value and that we respect. And, you know, it might be useful to get a wide range of feedback, you know, and ask for it and be open to it. Vague statements, time, yeah, not being trained. I think there's also something around fear of maybe upsetting people, not wanting to say the wrong thing, or damaging your professional relationship with them. You know, there may be differences in sex or age or hierarchy or cultural background that may sort of put some barriers in place. And again, yeah, poor handling of situations in which the recipient is resistant or defensive. And so, as you said, not receptive, it can result in a dismissive approach and therefore feedback will be disregarded. Something else as well, so in addition to time, so things like physical barriers, there's no point in, you know, pulling someone aside in a busy corridor, that or in the presence of other colleagues, that's not helpful. It loses its objectivity, and it, you know, the recipient may consider it as an insult. And yeah, work being seen. So, you know, it's very hard to give feedback on something that someone hasn't seen. So, you know, that being present, I think, is really important. Vague statements, absolutely infuriating. And yeah, as I said, it's that. I think because when people are involved, things get complicated. So it's, yeah, you've I think highlighted everything. Personality on both sides. Yeah, absolutely, exactly right. So some of you may have seen this before, but when we're talking about cultural differences and maybe some of our international medical graduate colleagues, this is something we use in we do a session on IMG supervisors or for international medical graduate supervisors, and for international medical graduates as well. And I think it can be quite challenging to understand, you know, reading through the lines of what people say. So for an example, very interesting, the British say, clearly nonsense, and someone takes it as they're impressed. But the problem is, I use the word, if someone says something to me that I want to think about, I'll say, oh, interesting. I haven't thought about that before. So I'm not at that point saying that's rubbish. It just means I've never thought about it. So it's confusing. My brother is married to an American girl, and he brought his American wife to visit my granny. And my sister-in-law was wearing sandals. And my granny turned around and went, "Are your feet not awful cold in those sandals?" And everyone in the family went, "Oh." Granny is raging. She is offended that that woman has worn sandals. Whereas my American sister-in-law was like, "Oh, that's so kind. She's worried about my health." Whereas no, Granny was furious. How do you navigate that? It's impossible. It's very, very challenging. So I think the onus is on all of us to just be aware of the language that we use and the way we phrase things can be challenging. And again, this is some research to highlight, and it just gives some really handy hints and tips. You know, do treat feedback as a conversation. It's a social interaction influenced by culture, values, expectations, personal histories, relationships, power. It's a conversation rather than a commodity. And do tailor it to the specific trainee as well. That's the individual trainee has to have reinforcement of key things that are done well, identification of key points, something that could have been done better, and then working out strategies for improving the quality of the work. Don't just go, oh, that wasn't good enough, without giving, help and support. How could it be improved? How could that specific trainee improve their work? And then giving specific feedback, focusing on how the task was done and how it should or might be done. And that's not to say that with everything there is only one right way. Sometimes, to use a British expression, there's more than one way to skin a cat. There's different ways of doing things. In other situations, there is only one right way, and you have to navigate that. Do ensure that the feedback is actionable. And as I said, enabling the trainee to construct strategies for an improvement, and providing guidance or scaffolding to enable them to step beyond their current competence. And the don'ts, don't assume that a single approach to feedback will be effective with all trainees. Not, especially, there may be autistic doctors that need different types of feedback. There's a whole range of things that have to be taken into account. And don't make assumptions. Don't assume you know exactly what a trainee wants to learn, why a trainee is struggling, why a trainee wants feedback, or what information that a trainee has taken out of a conversation. So you may have come across this before. It's very politely called the feedback sandwich here. And not to be crass, but in the vernacular, it's normally known as a shit sandwich, because someone says something nice and then they give you bad news and then they say something nice again. And pretty much, I would say, most of the feedback up until maybe about 4 or 5 years ago was using this model. And all it did was made me sit through the good bit, waiting for the bad bit, and then completely disregarding the good bit at the end. I mean, it may work for some people. Some people may love it. They may think that that's a really good way for working. But again, it's having those conversations. So it can soften the impact maybe of negative feedback. Has anyone come across this before? You haven't not been used with you? That's good. That's good. I don't know about those of you online, if any of you have come across it or had it used on you. Maybe it's more old-fashioned and isn't used much anymore. So yeah. And again, this is a different method, Pendleton's rules. I don't know if you've heard of this, but it asks 4 questions. What do you think went well? What do you think you could have done differently? What could be further improved? And how can that be achieved? So that's sort of scaffolding and assistance from the supervisor that we talked about. So that's 2 models. Don't think you're getting away that easily. There's also all of these, and there's probably more in addition. So I'm not going to go through each of these, but it's just to make you aware of the range and scope of feedback models that are available. And you may find ones that work for you and your situation. So again, as I said, I'm going to circulate the slides, so I won't go through each of these. But actually, what would be helpful, if any of you at home, if you have any other suggestions, you want to pop them in the chat, or anyone here, if you know of any different models that you've either used or had used with you, please feel free to let me know. Very gratefully. We're always trying to increase, the list that we can share with other colleagues. So how can you make conversations fairer? And the first thing I want to look at is I think the phrase cultural competence it has been used quite a lot. I think we're moving away from the phrase cultural competence. There was some work done by 2 doctors in America, and I'm embarrassed to say I can't remember their names. Possibly Trayvon is one of them. I'm sorry, but they're moving more towards using the phrase cultural humility. And this is more about having that learning culture. So that cultural competence, to give you this is not an example, but a rough idea of what I mean. Cultural competence, maybe you have had an international medical graduate from, I don't know, Iraq. And then you get another international medical graduate a few years later from Iraq, and you're like, that's okay. I've dealt with someone from Iraq. I know how to give feedback. I know how to support this person. Not necessarily. That's what we're talking about, is that cultural humility, cultural curiosity to find out about individuals, find out about different cultures. Because competence almost implies you've completed it. You have passed the test and you don't need to ask any more questions. So just something to think about. And again, it's terminology, that cultural humility. And just to pull out some paragraphs from Good Medical Practice, because it was recently updated, you may not be so familiar with these as you have been with previous iterations of Good Medical Practice. So we now say that you must, so this is a must, you must help to create a culture that is respectful, fair, supportive, and compassionate by role modeling behaviors. And you should be aware of how your behavior may influence others. That is a should, because sometimes we're not always aware of how we impact others, but you should try. And you should be aware of the risk of bias and consider how your own life experience, culture, and beliefs influence your interactions with others. And you must show sensitivity towards others' life experience, cultures, and beliefs. So just some paragraphs there from Good Medical Practice. So moving over to microaggressions, this is a report from 2023, and it talks about microvalidations being an antidote to microaggressions. And I think, especially as someone alluded to earlier, with the current situation that we're in, if we can't tackle the bigger wider scale problems, we have to focus on what's within our control, and we can absolutely focus on controlling how we act. And if we're told that something is a microaggression, then we're able to stop it. Yeah, getting someone's name wrong, I think that's a huge one. And we do a lot of work with international medical graduates, and it is challenging, I think. And I think someone raised the point that, their colleagues can say the names of really, really difficult drugs. They can say the names of footballers from all over the world, but they can't get my name right, which is pretty shocking. So yeah, absolutely, would agree with that. Misgendering, yeah, absolutely. Yeah, assuming education is worth less from another country, absolutely. Unfortunately, again, with working with international medical graduates, that's something I've come across, people telling me that. Yeah, absolutely. And just because something is done differently in another country doesn't mean that it's wrong. It's just, done differently. And, you know, okay, we might have to do things the way we do them in the NHS, but there's no need to diminish what is, you know, happens. Pronouncing name wrongly, yeah. Shortening name, yeah, absolutely, 100%. And then stereotyping around sports, interests, and hobbies. I think that's, yeah. Ah, yes. Not being included in team lunches or activities. Oh, being told to be more assertive as a person. Wow. That's awful. And these are all something that can be, you know, can be and should be easily remedied. Okay, fantastic. Thank you everyone for your contributions to that. I really do appreciate it. So, don't know if we've got any more. Let me check if there's any in my Teams chat. No, okay. So, yeah. Assumptions around specialty regarding gender. Yeah, absolutely. I've also had lots of doctors who are women who are, you know, they're assumed to be the nurse. They're assumed to not be, you know, a consultant. Yeah. So, you know, there's a lot of assumptions, and assuming someone's going to have a child, absolutely nobody's business what other people do. And yeah, 100%. Yeah. Really, thank you so much. Those are really, really important suggestions. Thank you. That is a good, unfortunately, a list. So what do we do about that? And there's this idea of micro validations. And again, this is something that we can all do. So acknowledge people's presence, validate their identity, and voice your appreciation for everyone's contributions. So not just the person who's maybe the loudest, but, you know, for everybody. Holding people to high standards, absolutely. Everyone should be held to the same standard, same high standard. And affirming leadership potential and status as well. So there's so much that everyone can do in this. Really so important. And yeah, just to fly through the resources, again, I am going to circulate the slides. The Equality, Diversity and Inclusion, that's the report that we publish each year where we talk about our targets and how we're doing against them. The Tackling Disadvantage in Medical Education, and a lot of work is going on behind the scenes as well to improve that. And then the Good Conversations, Fairer Feedback. And I also just wanted to highlight the General Medical Council Welcome and Valued. So this is for disabled learners. And I think just to stress, we need doctors from all over, all walks of life. We need doctors with disabilities to, you know, our patients reflect the world around us. So we really need doctors who reflect that world as well. So, for example, this is just one example pulled out. Does the doctor need help with their communication with colleagues and patients? And what reasonable adjustments may have been made for the doctor? For example, an autistic doctor could receive training to help support them. So the other resource around this is published, the National Autism Implementation Team. They're based out of Queen Margaret University, and they do a lot of work around creating neuroaffirming working environments. They have a lot of resources on their website, but I just wanted to pull out this one. This is around making adjustments for meetings. So for example, if there's that supervisee or trainee trainer meeting, maybe just having a think about, you know, would my trainee, do they have sensory needs? Do they need some processing space? Just something to think about. I think really, really important. And finally, just to pull this together as well, the Academy of Medical Royal Colleges has also published a report on improving feedback. So again, I will circulate the links to all of these resources along with the slides. So before I finish up, and I want to leave time for any questions. I will have a Menti slide so people can ask questions or give comments anonymously. And then I'll also have a feedback slide at the very end as well, if that's okay. This was a pilot session. As I say, it's normally a 3-hour session, so I've cut it down quite significantly. So any feedback on whether it works or whether it should be longer, gratefully received. So this is a summary, and I think the key point there, supervisory relationship is a key factor as to whether an IMG trainee is likely to be subject to differential attainment. And those traumatic negative feedback experiences can be formative events. And we want to avoid that at all costs. And yeah, just poor feedback can have a detrimental effect on trainee well-being. And again, just a reminder about bringing that cultural curiosity, cultural humility with you to work. So as I said, I forgot, I wanted to highlight this as well. This is from the Centre of Workforce Supply. They have an interactive online workshop for any internationally recruited staff. And it's an opportunity for international recruitments to gain information on how to develop their careers. So it's on the 25th of February. Yeah, and again, I'll send the links around to that, but I just wanted to make you aware that that was available. Also, there's a lot of information on TURAS for international medical graduates. There's an IMG hub. So yeah, just there's lots of resources there to highlight. So yeah, I will leave this up for any anonymous questions or comments, or please feel free to ask any in the room. And then I've got an evaluation slide for the session itself. So I'll leave this up for a minute or two, and then I'll pop the evaluation up. But just a huge thank you to you all for your time as well. And I'll also see if there are any questions in the chat. Let's have a look. Okay. Nothing there as yet. So thank you to everyone who's joined online as well. Very much appreciated. Okay. So, do you know, I don't know if we have information on class bias. I will ask the question. What I would say is, in good medical practice, we have broadened it out so that we ask that you shouldn't discriminate based on personal characteristics. So it's in our guidance, it's actually wider than the protected characteristics. So it includes social class, it includes appearance. So thank you for that question. I will go back and see if we have any specific data on it. I'm not sure we do at the moment, but even by feeding that question back, may trigger something. So thank you for that. Okay, brilliant. Any training or education? Yes, so we do a training session for international medical graduate supervisors. It's called Supporting a Multicultural Workforce. But I believe that NES also have a training session for international medical graduate supervisors as well. It's Professor Mo Al-Haddad in NHS Education Scotland that runs that. He used to do it with Dr. Charu Chopra, but I think she is not doing it anymore. But I believe that Professor Al-Haddad still is. Ooh, how do I think things compare to 20 or 30 years ago? That's a great question. So if I think back 20 or 30 years, I honestly don't know how to answer that. With regarding feedback or regarding, yes, okay, I have to confess, I don't know. I definitely was around 20, 30 years ago, but I don't know how to compare. I hope some things have got better, some things have got worse. Okay, if I can take my GMC hat off for a second. I'll answer the question about MAGA America. Full disclosure, I'm half American. My mother was American, and my brother still lives there. He lives in Colorado. And yeah, I think it is horrendous. I absolutely think it is horrendous. And I agree with you. I think being woke is a good thing. I think the phrase originated amongst the Black community, and it talked about being aware, and how anyone can think that being aware is a bad thing blows my mind. So that's my personal Christina McNiven view. I think it's horrendous. So, and I do, if I'll take it a step further, with reform on the rise in this country, I worry about that too. So thank you for that great question. I'm sorry, I will take that, as I say, very much. That's my GMC hat off. That's my own personal view. Okay, but great question, sadly, and I'm sad that you had to ask it. Okay, and I'm sorry I can't answer the 20 to 30 years ago. I think it's a really good question, but it's one, do you know what, I'm going to say interesting, and I'll go away and think about it. Is there any truth that people may just be a diversity fill? Oh, do you know, I think that's something that people talked about quite a while ago. Yeah, and I think that's awful if that is, and I'm sorry, it's how you feel, because it absolutely should not be. I think with all the employment legislation and hiring legislation, you know, it's, my personal opinion, again, and this is an American opinion, and I can't, what's the phrase? Oh gosh. Oh God, I can't remember the expression, but it was when people who had equal qualifications, but people from a minority, ethnic minority, were given the job over someone white. And I think in America that was absolutely, it was appropriate. That's my personal opinion. I think there was so many years of positive discrimination. Thank you. Yes, that's exactly right. And I, rightly or wrongly, I think it was a good thing. And clearly in America, I don't know if it's gone far enough, clearly. So there. Is it worth to keep quiet regarding child status to protect future prospects? I would hope not. People shouldn't be asking, what I'm assuming that question is, people shouldn't be asking you whether you're planning on having a family, whether you're a man or a woman. No one should be asking you whether you plan on having a family. So it shouldn't be a question that's being asked. So I'm really, really sorry that's there. So yes, you've had very much the Christina McNiven opinion piece for this question and answer. Again, I'll go away and find out from our standards, if there's anything specific regarding your questions that would be helpful as well. But thank you for asking them, and I'm sorry that from the questions that are being asked, it is challenging. So thank you. And yeah, just I would be very grateful for any feedback. As I said, 3-hour session condensed into 1 hour. So any thoughts on how we can improve that would be gratefully received. And then the final slide is my contact details. So if you have any questions at all, you can contact me after the session. But yeah, thank you for coming along, everyone. And yeah, you'll be able to get a certificate. If you're doing this on your phone, sometimes it won't allow you to fill in the certificate with your fairer feedback. But if that happens, just send the link to yourself, and you'll be able to do it on a laptop. And if you have any problems at all, just email me and I'll be able to help you out with your certificate for attendance. And again, thank you. Let's have a wee look. Nothing in the Teams chat. Okay. Just pop that slide up as well. So yes, you can contact either me or GMC Scotland, and as I said, your usual liaison advisor is Kirsten Baird. So you'll probably see Kirsten in future, or hopefully I'll see you as well at some point.